Good afternoon. Thank you very much to Ari and the organizer for this kind invitation. These are my conflict of interest. And this lecture is dedicated to Professor Santetura, who was the father of the modern hematology in Italy and one of my mentors. Lymphoproliferative disorders are complex, at least for two reasons. We have a very fast and significant advancement of knowledge as testified by two new WHO classification in a very short period of time, and because we are a sufficient quantity of biological material for sophisticated analysis is usually needed. The classification of lymphoproliferative disorders involving the lung is still complex, varying from benign hyperplastic disorders to atypical lymphoid hyperplasia, primary pulmonary lymphoid neoplasms, post-transplant, and secondary involvement by lymph node-based lymphoproliferative disorders. What we need to make a diagnosis of lymphoma or lymphoproliferative disease, we need, of course, morphologic evaluation, immunohistochemical study, but nowadays a long list of other investigations, including cytogenetics, chromosomal microarray, FISH, NGS, PCR, and so on. We can acquire material in different ways, from less invasive to more invasive approaches, starting from cytology to surgical lung biopsy. This is the new chapter, will be published soon in the third edition of ERS Handbook on Respiratory Medicine, and I thank Ari that provided with very interesting cases. And in this chapter you can have some idea about also the cytology of lymphoproliferative disorders in the lung, some rule of thumbs. An increase of polyclonal B-cell in BL fluid may suggest a diagnosis of follicular bronchiolitis or LIP. A CD4, significant CD4 cell lymphocytosis may be observed in high-grade B-cell lymphoma, so can mislead the diagnosis. Cytology, of course, may aid in the diagnosis, however, material may ultimately be insufficient for further investigations. This was a 39-year-old male with lung infiltrates and rapidly progressive respiratory failures, BL, had a huge lymphocytosis, mainly CD4 positive cells, but we will see later the diagnosis. This is a case of primary effusion lymphoma, pleural fluid. Of course, the cytology is very characteristic, but we need more information to have a final diagnosis. And this is a BL with atypical, but not so atypical lymphocytes, but with immune flow cytometry, you can document the monotypic expression of light chains, so the final diagnosis could be, or could be suggested, final diagnosis of mold lymphoma. But let's start with atypical lymphoid hyperplasia, Castleman disease, and IgG4-related disease. Castleman disease is a complex entity or a group of entity. At least 4 disorders can share similar characteristic histopathological features, but have complete different pathogenetic mechanisms. We have the unifocal, monocentric, we have multisystemic Castleman disease, multicentric Castleman disease related to HHV infection, POEMS, or idiopathic TAFRO, or not otherwise specified. Unicentric Castleman disease is usually, nowadays, is considered a clonal neoplasm. So it's no longer a giant hyperplastic lymph node, usually is asymptomatic. And this was a case, a patient who had a big lymph node, PET positive. We performed EBUS-guided cryobiopsy. You can appreciate the lymph node parenchymal architecture, burnout germinal centers, follicular germinal centers, rich in follicular dendritic cells and with typical lollipop aspects. Multifocal Castleman disease is another entity, complete different entity. Its distribution in the lung is perilymphatic, typically perilymphatic. This was a Nigerian 38-year-old male with fever of unknown origin, cough and nodules, centrilobular nodules, and the biopsy documented lymphocytic infiltrate and HHV positive cells, and the lymph nodes were positive for plasma cell variant of Castleman disease. Cryobiopsy, transbronchial cryobiopsy, has been reported to be useful in the final diagnosis of idiopathic multicentric Castleman disease. Here we have 4 cases compared to what was obtained by surgical lung biopsy by a Japanese group. And this disease can have some similarities with IgG4-related disease, more common. The lung involvement is more common, is a fibroinflammatory condition that can affect a variety of organs. It was identified as relapsing pancreatitis, but nowadays we can have also typical lung involvement. Lab test may be not characteristic. Interestingly, C reactive protein is usually normal and erythrocyte sedimentation rate is usually increased. We can have a peripheral eosinophilia, increased serum IgE levels, and also some flavor of autoimmunity in the serum. Pathological examination plays a key role in achieving a definite diagnosis. These are some cases with pleural involvement, pleural effusion, and this was a case with a mass in the lower left lobe and the lymphangitic distribution of the lesion. Cryobiopsy, the lesion is, we have nodules or we have involvement of perilymphatic structures. This inflammatory infiltrate is rich in plasma cells containing IgG4. So the final diagnosis was confirmed by cryobiopsy. And we have other data, other reports in the literature. Here one case also, IgG4 can involve mainly the tracheobronchial tree with PET positive thickening of the tracheal bronchial tree. You can have some differential diagnosis with amyloidosis, and cryobiopsy can be diagnostic. Move to the primary pulmonary lymphomas. The definition changed recently. Should be defined as primary pulmonary lymphoma and lymphoid neoplasm that become manifest first as respiratory diseases. Here's the list from low progressive disorders, low-grade malignancy disorder to very aggressive forms. Multiple lymphoma is the most frequent. Clinical profile is not typical. At least 30% of the cases can be asymptomatic. You can have a monoclonal spike in the serum. CT scan aspect can be suggestive. The differential diagnosis is mainly with ground glass entities or alveolar consolidation, so with adenocarcinoma is in the list of the differential diagnosis. And the disease is along the lymphatics in the lung and can coalesce in masses. We can have also ossification. It means that there is a combination of multiple lymphoma and amyloidosis, and we can have also cysts. This was a case with a perilymphatic distribution of the lesion. Cryobiopsy was diagnostic because the lymphoid infiltrate is mainly around the bronchovascular sheath and beneath the pleura. Light chain monotypic expression can be easily demonstrated in lung tissue. Amyloidosis is another entity. We can have different clinical expression from diffuse or septal amyloidosis, nodular amyloidosis, tracheobronchial amyloidosis, and now is considered, of course, a B-cell monoclonal entity. This is an involvement of the tracheobronchial tree, and this is a case of nodular amyloidosis, and you can have a diagnosis. Don't be afraid about bleeding, because if you read the textbooks, they say that amyloidosis can be a risk factor for major bleeding, but this is not our experience. Diffuse large B-cell lymphoma is the most common form of non-Hodgkin lymphoma in the lung. Nowadays, we have at least 10 subsets of large B-cell lymphoma, so it's an easy diagnosis as a group. Is a difficult diagnosis if you want to subset the entity. These are the biopsy, and this was a case with a cavitated lesion, and in the cryobiopsy you can see the cavitation, that the wall of the cavity is infiltrated by B lymphocytes, and around we have normal parenchyma, and you can reach the lesion using also, of course, radial EBUS under direct visual control. Intravascular B-cell lymphoma is another interesting entity, can be confused with thromboembolism or cases of unknown fever. This was a patient with dyspnea, fatigue, recurrent fever, an increase of pulmonary arterial pressure, and this is a red flag, a significant increase of LDH. Another case with subtle parenchymal involvement, and cryobiopsy was absolutely diagnostic. So cryobiopsies can be done also in patients with an increase of pulmonary artery pressure. Lymphomatoid granulomatosis, this entity was identified long time ago by Ariel Lieboff and Anne-Louise Katzenstein. The clinical spectrum can be very, very wide. Usually, the patient have respiratory symptoms, but at least up to 30% of them could be or can be asymptomatic. In the blood, you can have CD4 lymphopenia, and of course, serological evidence of ABV infection. In fact, nowadays it is considered an ABV-driven lymphoproliferation. We have different grades of malignancy, varying from grade 1 with few B cells infected by Epstein-Barr virus, and grade 3 that is a typical large B-cell lymphoma. Lymphomatoid granulomatosis in the lung can manifest with nodules, alveolar consolidation, cavitated nodules. And this was the 39-year-old male, non-smoker, that was admitted to our hospital for rapidly progressive respiratory failure, partially responsive to high-dose steroids. He had a CD4 lymphocytosis in BAL, and cryobiopsy was done even if he had respiratory failure, and we have now data that you can do in that way. The cryobiopsy was very typical. You see here we have angiocentric nodules, but in the lung we have only few B-positive atypical B cells. In the same examination, we performed EUS-guided needle aspiration of the adrenal gland, And in the lung, we have lymphomatoid granulomatosis grade 1, and in the adrenal gland, grade 3. T-cell lymphomas is even more complex compared to B-cell lymphomas. The more typical lymphoma manifesting in the lung is the extranodal natural killer T-cell lymphoma, nasal type, can manifest with systemic symptoms, hemophagocytic syndrome, rapidly progressive respiratory failure, and involvement of other organs, mainly the skin, can appear soon after pulmonary symptoms. One of the typical manifestations of the disease is the so-called hemophagocytic lymphohistiocytosis, and that can be tricky because the diagnosis can be difficult. And also, the patient, because of the significant lymphopenia, patient can be confused with a typical infection. This was a 58-year-old male, acute respiratory failure, hemophagocytic syndrome, and in BL we had cytomegalovirus and aspergillus, but we have also nodules in the lung, and the biopsy was diagnostic. We have an angiocentric angiodestructive process consisting of granzyme positive cells, CD3 positive cells, and positive for Eber, so infected by Epstein-Barr virus. We can also have lymphoproliferative disorder in specific settings. Of course, post-transplant is one of that, but this was a 39 female under treatment with natalizumab, that is a monoclonal antibody targeting alpha-4 integrin, and she was treated for atypical multiple sclerosis. She presented with asthenia, shortness of breath, and cytopenia with a lot of nodules. The lung was infiltrated by CD3 and CD4 positive cells, but the T-cell receptor clonal rearrangement analysis documented clonality of the process. And we also documented the infection by Eber. So the final diagnosis was EBV-related peripheral T-cell lymphoma, not otherwise specified. This was our experience with cryobiopsy in lymphoproliferative disorders in the lung, published almost 5 years ago. And in this study, we had analysis made for pathologists, and we have also some data on mediastinal cryobiopsy in the diagnosis of lymphoproliferative disorders. And this meta-analysis suggests that cryobiopsy can be more valid in this approach. But we have problems. The clinical reasoning remains fundamental. An increasing number of sophisticated analyses are required for accurate diagnosis and precise therapeutical planning. Is the tissue obtained from cryobiopsy, particularly mediastinal cryobiopsy, sufficient? And we have new entity to consider, mainly the so-called mediastinal gray zone lymphoma. We don't have data comparing cryobiopsy with more invasive approaches, and the role of trained hemopathologist is of utmost relevance in maximizing the utility of the retrieved samples. And because the pathologic report is a gold standard, studies should include an analysis of concordance, discordance, and among hemopathologists. Regarding mediastinal gray zone lymphoma, this was a biopsy in this context. This is a new entity of at least 5-6 years. And there is a combination of Hodgkin, typical nodular sclerosis, Hodgkin aspect, and large B-cell lymphoma. But the treatment is completely different compared to classic Hodgkin lymphoma. So one of the needs we have to explore is that the bioptic strategy for cryobiopsy in lymphoproliferative disorders in in the mediastinum has a role. We can also some help from the rapid on-site assessment. We have two papers published, one paper published with Ari Gonunguntle, and we have another with confocal laser microscope, and the other one is a study that the revision version is already submitted using another kind of microscope in order to have a rapid on-site assessment of cryobiopsy. Having said that, I want to thank all my co-workers, our cardiothoracic radiologist, Sara Picciucchi, our pathologist, and all my group, and the fellows that we guest every day. Thank you very much for your attention.